on my ears.
Oh.
Like, this is ridiculous.
Okay. All right, let's begin. We're a lively group today. All the stress from the test is dissipated. Yeah, so this is finishing up Head and Neck 1. Because, you know, we stopped early to do that little review thing. Yeah.
Oh, it's like the very long. I was like, when last night?
Almost. Okay.
Yeah, you are.
So, we just finished looking at the dermatomes of the head and neck, and remember what was different about those is we do have some dermatomes that are innervated by the posterior rami of the spinal nerve. It's not just the anterior rami. So now let's look at some of the structures that are important in swallowing, breathing, and the ones that prevent breathing of the wrong stuff. So preventing things getting down the airway. So there's 3 groups of tissues that are important for this. We talked about the soft palate. So that's going to prevent reflux of food up into the nasopharynx. Okay. The epiglottis that controls the opening of the laryngeal inlet. And then finally the vocal folds and other soft tissues in that region that help prevent large objects from passing down through the larynx into the trachea. Okay. So this is kind of last defense. If you get past the epiglottis and the soft palate, then that's your last defense is the vocal folds there. So then during normal breathing, we have the soft palate either in a neutral position, which means you can breathe through your mouth or your nose, and the epiglottis is up, so the laryngeal inlet is open, and then the laryngeal cavity, so those soft tissues haven't come together to occlude the laryngeal cavity. There's open space for the air to flow there. Also during breathing can close the oropharyngeal isthmus, so the passageway between the oral cavity and the oral pharynx, by depressing the palate and elevating the back of the tongue. So this would be like being able to breathe while you chew and stuff like that. Okay, breathe while you have a mouthful of water. So breathing just in through your nose there. Okay, and then for swallowing, obviously the soft palate elevates, and so that opens the oral or pharyngeal isthmus. The epiglottis closes down over the laryngeal inlet, and then the hyoid bone and all the strap muscles and everything help pull the larynx up and forward a little bit to open the esophagus, allow the food bolus to travel down. Okay. Questions? Pretty clear? Cool. All right, so in infants, they have a modification of this that helps facilitate breastfeeding in a timely manner. So infants in the first 6 to 9 months of life can swallow and breathe at the same time. Otherwise, they breastfeed like 24/7. So what it is the laryngeal inlet is elevated. So the larynx actually comes up and extends up into the pharynx a little bit. So that allows the laryngeal inlet to stay open, and the milk can flow down around the tube that forms the larynx, goes around it, and still they can swallow and breathe at the same time. This starts dropping at about age 6 to 9 months, so they have to learn that they can't swallow and breathe at the same time, so that's a time when they do a lot of coughing and spluttering and things like that. Okay? Excuse me. Okay, and then the final slide for this one, the posterior and anterior triangles of the neck. So these are regions that allow good access to structures of the neck or the axillary inlet. So the posterior triangle allows good access to structures in the axillary inlet region. And it's between the clavicle, the trapezius, and the sternocleidomastoid muscle. The anterior triangle allows for access to structures of the neck, and that runs between the anterior midline of the neck, the anterior border of the sternocleidomastoid, and the inferior border of the mandible. So these would be where you would gain access for like a surgical procedure on a structure in the area. Okay. All right, so got done with that one. We'll switch over to today's lecture. So now we'll start getting into regional anatomy. Excuse me. And at least for the skull, what I'm going to have you guys do is you've got a lab list. You're going to know those anyways, so just make sure you know them on these diagrams too. I'm not going to go over the bones because that would be really boring and take forever. So what I'm going to do is just point out a few things of interest as we go along through these different diagrams, but do know the structure, be able to identify them on the diagram, the ones that are on your lab list. Okay. So we'll start off with the pterion here. The pterion is the region where the parietal, frontal, temporal, and sphenoid bones all come together. This is located at the temple region, so where we think of the temple on our heads. And it's important because this is an area that's quite easily fractured with trauma. Okay. Now, because it has all of these sutures coming together, that means when it's fractured, often there are fragments of bone that can lacerate underlying vessels and cause an extradural hematoma. So that's an area where trauma to the head may end up causing a problem like that. The vessel that underlies it is the middle meningeal artery, and we'll look at that later. Okay. Now remember, the mastoid process is one of the points that defines the difference between the neck and the head. Also an important muscle attachment point. For this one, just wanted to point out the superior nuchal line and the external occipital protuberance. Yeah, I finally said that word properly the first time. Okay, so remember, this is again one of the borders between the head and the neck, and this one of the palpable ones. Okay. Enough on that one. Okay, so remember I talked about the fontanelles that develop, or that are kind of there in the newborn and finally ossify over as the child reaches a couple of years old. Well, those regions are called the bregma, so this would be the previous location of the anterior fontanelle, and that's that location where the sutures of the coronal suture and the sagittal suture meet. And then the lambda, where the lambdoid and sagittal sutures meet, and this would have been the anterior. Posterior, thank you. Fontanelle. Okay. Next, so bottom of the skull, lots of foramina. And remember, foramina are round, smooth-edged holes, and those are typically passageways for structures leaving or entering the cranial vault, or often those are going to be cranial nerves. I'm not going to have you know all of the foramina because there's a lot of them, and it's not going to help you that much as practitioners. But just remember, we have all of these foramina for those cranial nerves and then the vasculature that's leaving and entering the cranial cavity. One that obviously we probably all know already is the foramen magnum. So what structure passes through that? Spinal cord, right. So then there's a couple things. You can have a abnormal narrowing of the foramen magnum. This can be either developmental, it just doesn't grow very big, or it can be because of a mass growing in the area, often a meningioma, meningeal tumor, and that would cause compression then of the spinal cord. Another clinical, good heavens, I should get more than 5 hours of sleep. Clinically relevant thing is if the cranial cavity, especially the region here, at the back part where the cerebellum sits, is extra small, actually put increased cranial pressure and cause parts of the cerebellum to move down into the foramen magnum and maybe some of the brainstem as well, and can cause compression of those structures. And that is what we call the Chiari malformation. So those are going to cause all kinds of neurological symptoms as a result. Okay?
Just a real quick comment about
Yeah.
that. My cousin, they actually thought she had this.
Oh, really?
because She's experienced like terrible headaches for years.
Mhm.
And she's actually like started having numbness and tingling in the lower like limbs and everything
Oh,
like
my.
that, and started getting like balance problems. And she's
Mhm.
like a physical therapist, focuses on headaches, so she was just
Oh,
freaking
my.
out.
Yeah.
But apparently, like you can only diagnose it through like an MRI, and thank goodness she didn't have it. But I just thought it was interesting. I mean,
Yeah.
I think with the cerebellum, obviously, like balance and coordination.
Yeah, it would cause a lot of those problems, and unfortunately there's a lot of things that can cause damage to the cerebellum, anything that increases intracranial pressure. But this Chiari malformation, I have a friend who has it, and part of her brainstem and her cerebellum have extended down through the foramen magnum, and she has so much pain. I'm just like, it's unreal how much pain that woman goes through.
Did she have any like hemorrhages?
No.
With hers? I know it's like one of the types of it, but.
No, I think hers is a little less severe, but it just causes a huge amount of pain in like her upper extremities especially. So she has one of those implanted nerve stimulators to try to deal with the pain. I mean, it's just crazy.
Can they not, like, increase the size of the foramen or something to?
I don't really know how they treat that. Like, if the foramen magnum is too small, yeah, they definitely go out and they chisel the bone out a little bit and make the area larger. For a problem origin where the origin is the size of the cranial vault, I'm not sure what they would end up doing, because you don't want to open it too wide and let things fall through more, because that could change what you're compressing to. I don't really know what their treatment is for sure. Has anybody heard of anything? No? Okay. Anyways, very interesting. I'm really glad that your friend doesn't have that. Okay, what's next? Oh, yes, so this is the deep surface of the skull. So this is looking up into the top part of the skull. So here's our frontal bone here. The parietal bones, our sagittal suture. We have a couple of things I want to point out here. So here's the grooves for the middle meningeal artery. So you can see it's very tightly associated with the bone, and so the region that's tightly associated with the temple, that's the reason why the fractures in that region are going to be a problem. Also, I'm going to point out the granular foveolae. These are little divots in the deep surface of the skull, and they are the location of arachnoid granulae. Granulations, there we go, get the name straight. So can't spell today, let's try this again. Granulations, and these are little outpouchings of the arachnoid mater and subarachnoid space that is important for recycling of cerebral spinal fluid, and we'll hit those again in a few slides. But what happens is they actually cause a divot in the deep surface of the skull when they form. Okay. Oh, come on, go forward, you silly thing. Okay, so then if we look at the bottom half of the skull, so the inferior half of the skull inside, so this is the anterior portion. Here's the frontal bone here. We have the cribriform plate. Does anybody know where the cribriform plate is located? Up one more level.
Kind of know.
Yeah, so that's the location of the nasal epithelium. Okay? So this is the bone that separates the nasal epithelium from the brain. It has a lot of little holes in it, little foramina, and that is to allow the axons of the olfactory receptor neurons to pass from the olfactory epithelium at the top of the nasal cavity up to the olfactory bulb. So the olfactory bulbs would be sitting right here, kind of like that. So you'd have all of those neurons coming in and innervating the glomerula of the olfactory bulb. It's too bad we can't talk about it more, because that's what I studied. I like olfaction, it's good stuff. Okay, so that's the cribriform plate. Okay, here, I'll just point out the hypophyseal fossa. So this is a little cup-shaped structure of the brain. This is where the pituitary gland sits. Okay, that's where the pituitary gland sits. And then we have the optic canals in here. They don't show them very well, but they're going to be just little canals here. That's where the optic nerve is going to come in to the brain from the orbital cavities, and also the ophthalmic artery is going to go out to the eye to supply the eye. Okay. Oh, go forward, you silly thing. There we go. And then here, just the internal acoustic meatus. So this would be the location, kind of the bridge between the inner ear and the brain. So the nerve that comes through that is going to be the vestibulocochlear nerve. So that would be the auditory nerve and the vestibular nerve come together. And make sure I got that name right. Where did they put it? Yes, vestibulocochlear nerve. I always want to switch them around and call it the cochlear vestibular nerve. I don't know why. Okay. So that's that. All right, so those are just some clinically relevant locations of the skull, but then again, just remember to know the same structures as you do for lab. So, characteristics of skull fractures. What's one that we talked about when we were talking about pelvic fractures? Usually it's
Circular.
multiple fractures, yeah. So, because it is a circular structure, so like the wonderful example of cracking a hard-boiled egg, or that shell is going to fracture in multiple different locations. You can have a depressed fracture where the fragments are pushed in to the cranial vault, so that can cause compression and on the brain there, and hematomas, like a lot of extradural hematomas related to skull fractures. Or you can have compound, which would mean it's associated with a laceration of the scalp, and you're going to have potential fragments lacerating the scalp, and potential route for infection to come in. So a couple different things, and then often associated with those extradural hematomas, because of the meningeal vessels, the meningeal arteries are so tightly associated with the skull bone. Anytime it fractures, that's very often lacerating them. Okay, so skull fractures. All right, so let's go in a layer to the meninges, and remember the meninges are what? What kind of tissue? Connective tissue? How many layers? 3 main layers, right? So we have the outer layer is the dura mater. And there's actually 2 layers of the dura mater. The outer periosteal layer, which is tightly adhered to the bone. So, and then we have the inner meningeal layer, which is associated with the arachnoid mater. So then our next layer obviously would be the arachnoid mater. It's a thinner membrane, and it sends these trabeculae, so all of these little fun green lines in here, sends these trabeculae in through the subarachnoid space and attaches it to the pia mater, our final layer there. And then the pia mater is adhered to the surface of the brain. Okay. So then we have between the arachnoid mater and the pia mater, we have this subarachnoid space. What fills that? Cerebrospinal fluid. Good. And then remember from our overview way back at the beginning of the semester about the turn of the century, we had continuous meningeal layers between the cranial meninge and the spinal meninge. So it's all one continuous layer. And then you have little extensions of the meninges out along the roots of the spinal nerves. So then the spinal nerve would come out here, like this, to help protect that root of the spinal nerve before it exits the vertebral column. So those are the meninges. There are portions of the dura, the inner meningeal layer of the dura, that reflect down in. This is what we call a dural partition here. So you can see it reflecting down in between parts of the brain. And then finally here we have these spaces between the 2 dural layers that we call the dural venous. Well, I can't write there. I'll have to go up here. Venous sinuses. All right. So here's the dural partitions. There's 2 of them that are really important to know. The falx cerebri, and this is a partition that goes between the 2 hemispheres, so separates the hemispheres of the brain. those cerebral hemispheres. And then we have the tentorium cerebelli, which separates the cerebrum from the cerebellum. Okay. These also provide kind of a structure for those dural venous sinuses, so they run within these partitions. Okay. All right. So here's a cross section of the dural venous sinus, and the whole point of having them is to be able to drain our cerebral veins. So these are the veins that are coming, gathering blood that's coming out of the brain tissue. So all those small veins that go through the nervous tissue. Diploic veins that help supply the skull, and then emissary veins that drain blood from the scalp. These emissary veins can be a bit of a problem because they don't have any valves, and so they're kind of just an open traffic to the outside. So if there's any, like a scalp laceration or something like that, infection can get into the brain via these emissary veins. So lovely little trade routes for infection. Okay. So then all of the blood from all these veins empties into these dural venous sinuses, and we'll look at several of them, and they all empty into the internal jugular. Okay. So here are those venous sinuses. There's a few of them that I want you to know. So we have the superior and inferior sagittal sinuses. So the superior one runs along the superior part of the falx cerebri. Wow, couldn't remember that name for a second. And the superior one runs just over the top of the corpus callosum. This inferior sagittal sinus drains into the straight sinus, and then the straight sinus and the superior sagittal sinus drain into the confluence of sinuses. Those both then drain into the right and left transverse sinuses. And there it goes to the sigmoid sinuses, and then to the internal jugular vein, which they don't show on here very well. Absolutely. So we have the inferior sagittal sinus that drains into the straight sinus here. And then both the straight sinus and the superior sagittal sinus drain into the confluence of the sinuses. The confluence of the sinuses goes to the transverse sinuses, the right and left transverse sinuses. Those then flow into the right and left sigmoid sinuses. And then that finally drains into the internal jugular.
And did you say that the superior or inferior runs along the superior falx cerebri?
So the superior sagittal sinus runs along the superior part of the falx cerebri. So here's the falx cerebri here. And then the inferior one runs along the inferior portion of it. So they both run along it, just one superior, one inferior. All right. So that's kind of the cerebral portions. Then we have the cavernous sinus, and this is kind of a network sinus. So this is actually a plexus of veins. And it receives blood from several different structures, but I'll just point out the ophthalmic vein coming from the face. So it's going to drain blood from the face into the cavernous sinus, and then it's going to go to the internal jugular vein as well. Got it? All right, so then here's that cavernous sinus. So you can see it's a whole network of little veins here. So it's a whole plexus of veins. And it surrounds some structures that I want you to be aware of. So it surrounds the pituitary gland, the internal carotid artery, and several cranial nerves. So we've got the trochlear, the oculomotor, the abducent, and then 2 of the divisions of the trigeminal nerve here. So those are all passed through this cavernous sinuses. We also have the optic chiasm up here. And remember, the optic chiasm is that point where the optic nerves cross over and share some of their fibers together. Okay, so why is it important to know this? No, you can have infection of the cavernous sinus and would obviously cause inflammation and compress these structures. And so you've got a lot of neurological and potential endocrine symptoms from infection of that. Infection of that is called, I'll have to look it up again because I forgot, cavernous sinus thrombophlebitis. Okay, so that can cause compression of all of these structures contained in there. Cavernous sinus. Okay. Any questions, comments? Okay. So, remember our ophthalmic veins are draining from parts of the face, and especially the veins draining this region of the face. They call it the danger triangle. Dun, dun, dun. I just needed to have that music. it just fit. And so infections in this part of the face can have basically a straight shot into the cavernous sinus, and so can lead to infections of the cavernous sinus, and if that spreads, then infections more widely in the brain. So I guess that's why they keep telling you not to pick your zits or whatever, is that infection, if it gets in there, can actually travel back to the brain and affect the brain. Yeah, that's about all I had to say about that. Okay, so then remember we talked about those little divots in the inside of the skull. They're called the granular foveolae. Well, here are the inhabitants of that. Sometimes they can reach up and form little divots in the skull, these arachnoid granulations. So these are outpouchings of the arachnoid mater, and then the subarachnoid space filled with CSF that pouch out into these dorsal venous sinus. And they are important for reabsorption of cerebral spinal fluid. So cerebral spinal fluid is produced in the walls of the ventricles of the brain. Sorry? Yes. That's hilarious. I'm making some pretty amazing typos this week. It's pretty impressive. Okay, so cerebral spinal fluid is produced in the ventricles, walls of the ventricles of the brain, so this is those fluid-filled spaces, and travels throughout the subarachnoid space, and then it needs to be recycled to replenish it and to make sure that has the right composition, all of that. So it gets reabsorbed back into the blood here and gets recycled in that way.
Gets recycled to the
Yeah, so it gets, well, it gets put into the blood, and so what the choroid plexus in the walls of the ventricles does is it formulates the cerebral spinal fluid from components of blood plasma. And so it kind of just allows for recirculation of that fluid, maintaining proper composition of it. Also, it allows for removal of any particulate matter, so decaying dead cells, any foreign invading cells, so the bacteria or viruses, whatever, helps clean those out of the system. Okay, so all these meninges need a lot of blood supply. So, like I said, one of the major ones is the middle meningeal artery. And so here's the pterion again. You can see how closely associated the middle meningeal artery is with the pterion. So fractures of that pterion is very often leads to an extradermal hematoma. And because it's such a large artery, they can be rather severe. This middle meningeal artery supplies the majority of the meninges. There's just a few little other arteries and branches of arteries that kind of fill in the spaces. So you have anterior meningeal arteries, posterior meningeal arteries, and then a whole bunch of branches that kind of help fill in. These are all branches, at least the middle meningeal artery is a branch off of the maxillary artery. So, which is in turn a branch off of the external carotid. So external carotid, maxillary, middle meningeal artery. Okay. All right. Anatomy of the brain, yay. So sad we can't go more in detail. It's very sad. All right, so I'm sure you guys are all familiar with the lobes of the brain, different lobes. Make sure you remember the different major functions that each of the lobes of the cerebral hemispheres plays. And then obviously we have our cerebrum, or cerebellum down below, in charge of a lot of motor coordination. Then we have, if we look at a mid-sagittal section, we have the connection between the two cerebral hemispheres would be the corpus callosum. And then moving down from there, we start getting into some of the other regions of the brain we need to be aware of. So below the corpus callosum is the thalamus. Remember, that's kind of the relay center of the brain, so most information coming into the brain and passed between different portions of the cerebrum is all pushed through the thalamus, kind of as a gating mechanism. Hypothalamus down below that, a lot of function with maintaining homeostasis, including controlling the pituitary gland down here. And then we have the brainstem. So first part of the brainstem is the midbrain, directly under the thalamus. Then the pons, kind of the funny little structure protruding out here. And then the medulla oblongata. The medulla oblongata then terminates at the level of the foramen magnum, and we've got the spinal cord down below that. Okay. Now, I couldn't help myself because I am a neurobiologist and I had to put something extra not in your book. This is just a reminder of the ventricles. So remember we talked about them with the cerebral spinal fluid. So the choroid plexus is kind of on the walls of the ventricles, like right back here and through here, producing the cerebral spinal fluid, and then those ventricles are filled with it, and then there's then branching out from that the subarachnoid space, allowing for circulation of the cerebral spinal fluid throughout. So, reason it's important to just remember kind of the shape, location of the ventricles is obviously they're going to show up in brain MRIs, things like that. So, making sure you remember that that large hole is supposed to be there. Okay. If we have blockage of cerebrospinal fluid circulation, or somehow overproduction of circulation, or somehow it's not being reabsorbed as much, then we can get enlargement of these ventricles. Excuse me. And that would be called hydrocephalus. Water in the head. Okay. All right. Any questions about anything? Too bad we can't do more brain. It's so cool. All right. We'll see you guys tomorrow.
I would love, to understand it all, but it's just so much stuff.
Question.
Yes, ma'am.
So for depressed fractures, did you say that is also, are these both associated with extradural, or is
Absolutely.
okay?
Yeah, both of them are often. So this is just two different ways you can have it. You can have
Right.
depression, or you can have them coming out the
Okay,
other way.
I wasn't sure if you said, I didn't know if I heard intracranial or extradural. So
Extradural, yeah.
Okay.
Intracranial, you might get some intracranial with a depressed fracture because it's just compressing
right.
the underlying brain tissue and all of that. It might sever something, but you're in a bad way if that's happening.
Yeah.
Real bad way.
Do decent well.
Yeah.
Okay.
So,
Thank you. I just wanted to clarify.
how you doing?
It's terrible.
Aw.
And I don't know if, like, today, I don't know if it's just worse because of, like, the elections and stuff like that. And, like, stress is making it really bad. But, like, I need to go nap.
Yeah, get
Or
some
just, like,
rest.
relax.
For sure. How's studying coming for the exam?
It's okay.
Yeah.
I'm definitely not ready now, but
Yeah.
hopefully within, like, 2 days it'll be a little bit better.
Okay, just let me know because it does take a while for those symptoms to
Yeah, that's what I was like
subside.
wondering. Is like, I mean, because they told me that I should go check back in with my regular doctor this week, and I was like, oh, maybe I can get by without it. But like,
Yeah, it'd be a good idea to check in.
and do you know what they usually recommend?
It's just going to kind of keep an eye on it and just, because sometimes maybe at like the beginning there may be something that they wasn't recognizable at that point. So you don't want to mess with it when it's a concussion. So, if there's just like a tiny bleed or something like that, then you want to see that.
Sure. So
Yeah.
if I went and checked in with my regular doctor, though, would they do another CT scan?
Probably not.
think
They would
so,
just
unless
kind
something was, like,
of right. If you
blatant.
started getting worse in some respects, so like today's a little bit more stressful, so yeah, you're gonna feel a little bit worse. But if you started again having more and more
Same.
escalating problems, then that could be an issue. But yeah, just having periodic check-ins so that they know how well you're healing
Yeah.
is important because sometimes we don't catch that when we're in the injured state because your brain's just not working the way it normally
Like, it
does.
was embarrassing when I went to the ER. I was like, they were asking me like medications, and I forgot like medications they take every day, and just like little things like that. And like, I was like talking, I was eating ice cream last week, and I like kept calling cherries like strawberry, like just stupid stuff.
Yeah, because your brain just got bounced around a little bit, and it really messes it up.
I was gonna say, even though it's like minor, moderate, like I can't even, I don't know. I
Yeah.
mean, like I'm definitely feeling the effects. I can't imagine if it, like these, like for example, Tommy Armstrong got a pretty good whack in the head.
I don't know how he was up walking around just a few minutes later. I was just like, "Hey, dude, you're amazing." But
Right?
yeah, no, it takes a while because you cause inflammation in your brain, and as soon as inflammation starts, then all of those circuits are now compressed and they can't work the way they normally do.
Like,
I mean, I just feel
would
bad.
you
You know, like I don't like.
I know that ibuprofen is an NSAID, so would you recommend that I stay away from that, even though like they said that there was no bleeding? Or would you say Tylenol?
Any of those, like Tylenol is definitely going to be. I think it does a little more blood thinning than ibuprofen, doesn't it? I mean, aspirin's definitely
Aspirin,
out. Yeah. But
I didn't think Tylenol's not an NSAID, is it?
yeah, it is.
It is? Oh, I
Mhm.
thought that was like one of the only ones that wasn't, like acetaminophen.
I thought it was, but I mean, I don't know my drugs very well.
Me either.
Pharmacology, just wait,
Right?
right? Yeah, oh, well, just keep me posted, and if you're still feeling pretty terrible on Friday, we can like come
I
in
just
on
feel so
Sunday or
bad,
something.
like keep pushing it back. I'll try
but
to
it's
think
not
of-
your fault.
I know, but still, like
Yeah,
to
but-
make students wait for their exam scores.
Well, actually, I gave people their
Good,
overall
good,
scores,
good.
and so
So
they
I
at
just-
least know how they did if they wanted to know. So yeah, it's okay if we push it back. We just want to make sure that you've gotten back to the point where you can do a good job that's reflective of what you actually know, not reflective of the fact that your brain's kind of this.
Yeah.
I just was a basketball phase, right? So yeah, I'd be happy to come in on Sunday and we could just sit there and take as long as you need to take it and just make sure that.
I'll let you know by tomorrow, hopefully,
Okay.
how I'm feeling. Like, I'm gonna go home and rest for a while, and then I'll try to crank some out for
Okay.
that end lab.
Okay, sounds
Thank
good.
you.
Mhm.
Probably, like, once I leave lab, I'll probably, like, later.